all, it's just fun to be here at the summit. You know, I hope to come to summit number 1 and summit number 2, but you know, life gets in the way sometimes. Just couldn't make it. I heard such good things about it. And then when I heard number 3 was going to be within a 2-3 hour drive from Charleston, South Carolina, I said, okay, we got to make this one. And it's really exciting to be here. Familiar faces, new faces, to hear what's happening out in the primary care world in our profession. It's been a lot of fun so far, and again, really, really exciting to be here. And of course, to have this opportunity is a privilege. I appreciate the program committee and the invitation. It's an opportunity to kind of express ideas and thoughts, but for me, as much as it was reflection and how much has changed in the PT and primary care world over the years. You know, Evan mentioned a number of these. Just look what's happened in the last 12 to 15 months. You know, for somebody who's been nibbling on the corners of primary care for almost 40 years, I never would have guessed all this would be happening within a 12-month time frame. I mean, we have hit the radar screen. It's really unbelievable, all the things that come out at a national level. And certainly things are happening at state levels and, you know, practice levels as well. But the recognition at the national level of our role in this model, what it can be, what it is, it should be, it's hit the streets. Evan mentioned a majority of this, but the one on the bottom is really brand new. Just within the last couple of weeks, the Foundation for PT Research has reached out. Their board of trustees is exploring primary care as a funding area within their grant and scholarship mechanisms, which is something they've never considered before. So research chair, whoever you are out here, the foundation will be knocking on your door and our door to get some feedback regarding this potential. A huge opportunity to push this practice model. So it's an amazing time, a really exciting time. And in terms of congratulations, individuals have been highlighted already, but really everybody in this room has had a role of what has happened, especially in the last couple of years. Whether it's at the clinical level, health systems level, your teaching, the education programs that are out there, and also what you're doing from the advocacy perspective. I mean, what Ashley just described doesn't happen with all that grassroots activity that has just been there under the surface for a long, long time. So, my goal over the next 45 minutes or so is to describe a bit of the journey that led to the recent successes. I'm going to mix in part of my personal journey along with the profession's journey, at least from my eyeballs, what I eyeballed over the years. And of course, the journey's not done yet. So once we kind of come up to date, then we'll take a look into the future and kind of what's next, what's around the corner for us. And that ties into the title of this, it's game time. There's a huge opportunity out there waiting for us that I'd like to think we're going to be ready for. But we've not had an opportunity like this, in my regard, as a profession, to really move the needle than what we have right now, which again makes it a really exciting time. So the beginning, I mean, Evan mentioned this, and everybody here is aware of this. You can't talk about primary care starting here in the US without going back to the military. And the original military model, the idea of the physician extender and the triaging and the patient management that was happening, again, that was driven by a need, as Evan said, a physician shortage. So there was an opening, there was an opportunity there that the PTs were ready and moved into it in collaboration with the orthopedic surgeons. Now, my guess is that the military model back in the early 70s, post-Vietnam and peacetime, probably doesn't quite fit the exact definition we now have of primary care, but it certainly is the precursor of where we have landed to date. So kudos to the military being ready when the opportunity presented itself, and that model has just evolved over time as it has in the civilian sector. So a little bit about my personal background and my personal journey. My introduction to primary care, I've been out of PT school for about 8 or 9 years. And Joe and I moved to Minneapolis, St. Paul and joined a private practice at their PTOSI. And we'd been there about a year and we moved to another place. It just happened that our neighbor was Charlie Bass, who was the family practice physician in the Twin Cities. And so became friends with Charlie, and we didn't talk shop all the time, but he was there, he was ready for me, and he liked talking about things and exploring each other's practices. So I kind of learned from him what primary care meant to him in terms of day-to-day responsibilities and what his training and background was. And of course, I gave him the PT perspective as well. And we slowly realized that, yes, there's some overlap in our training and roles responsibilities. We complement each other's backgrounds and training and clinical abilities. We kind of covered each other's gaps. And then about 6 to 12 months after that, I connected with Mike Koopmeiners, another family practice physician up in the Twin Cities. And those of you in the VA in the Twin Cities be familiar with Mike. And he became a friend and really another role model for me. Gave me just another perspective of family medicine and some of the challenges that they faced day to day that were similar to some of the challenges that we faced. So, you know, reimbursement was an issue, trying to gain respect to from your referral sources. You know, Mike and Charlie both would complain about this orthopedic surgeon. I send them patients, they blow me off, they don't listen to me. Cardiologist blew me off the other day, hung up on me when I tried to talk about a patient. It's like, well, I can kind of relate to that too. You know, especially back in those days when physicians weren't expecting PTs calling them expressing health status concerns about a patient of theirs. And with Mike, also, I taught courses with him for about 10 years. And again, has been a big friend of our profession. He's helped health systems. He's always been an ambassador for our profession, opening doors for us within health systems. And of course, he gets no kudos from his physician colleagues for working on our behalf like this. Great guy, and really helped me explore again what primary care was, is, can be, and how physical therapy can fit into that model. And then Tom Best, that ties into kind of the next phase of me. So that was like in 86, 87, early 88, especially with Charlie and with Mike. And then mid-1990s, I entered the Doctor Health Science program at the University of St. Augustine, Stanley Parrish's program. And what drew me to that program was there was flexibility, in essence, to create your own program. I mean, you had to meet certain criteria, of course. And but at that point, primary care, I wanted to get into this deeper. And so I was able to create a program centered around primary care. And part of the experience was a practicum. So I spent a number of half days in the clinic with Tom Best, family practice physician at University of Wisconsin-Madison. And then kind of my chore was, I kept a log of every patient we saw that was coming in to see him. And this log was what brought the patient in, and was there a potential role for physical therapists to play? And probably 80% of the patients who came in, the answer was yes. So we debrief and we'd exchange ideas, and again, I left with a much better, deeper respect for his role, responsibilities. I mean, there were days where he saw a 2-week-old baby for a well baby check, and then later on somebody in their 90s, and everything in between. It was kind of mind-boggling what he had, the decisions he had to make with this huge variety of patients. And plus, I'd like to think I gave him a better understanding of how PT might fit into this role, provide a role that fits into this model. And then Michael Bain and Ivan Matsui. So about this time, good friends Carol Jo Titchener, who was chairing the Northern California Kaiser Fellowship Program, we were talking, so well, you need to come out and spend some time in our clinic, because we just started a primary care model where the internists in that system, they were overwhelmed, and they knew about this fellowship program. So they knocked on the PT fellowship door and said, we need help. A quarter of our patient population are MSK patients in general. That's not in our wheelhouse. We understand it's in your wheelhouse. Can we collaborate here? And so I went out to Northern California and spent some time both with Michael and Ivan. And it was just neat to see the decisions they were making on a routine, regular basis. It was neat to see the respect that they had earned from these interns that opened the door for that physical therapy group. Another part of this experience for me, and really helped open my eyes, was I took a couple courses in the PA program up at the University of Wisconsin, and those credits transferred down to St. Augustine. And I was excited. There was a clinical medicine series. So I'm in there, coming in with my PT perspective, taking notes, thinking how this applies to my practice. And then we had the first exam. and I got a D minus. Oh my God, I haven't gotten a D at least in a couple of years. And so I went in and talked to the instructor, and I said, I'm doing something wrong here. And she said, well, yes, Phil, you are. She said, it's clear when you're in class, you're wearing your PT hat. This is not a class for physical therapists. We're preparing physician assistants. So you've got to leave your PT hat out in the hallway and come in with no hat at all or start wearing a different hat. And that was a really good lesson for me to finally understand over time. It was the last D minus I got in that class, and the passing, thankfully. But just it was taking that PT hat off was really critical, opening my eyes to other elements of the healthcare system, the training, background, experiences. Again, I was able to take that back into my own practice and the PT model, but it was really important for me to take my PT hat off. And this also goes back to the beginning. I think it was important, my initial role models were not physical therapists with a similar biases that I had. They were physicians, and just really gave an appreciation that, hey, we're not in this alone. There are collaborators out there, and if we complement one another, it can really help each other towards the common goal of quality patient care. So that doctoral health science program was really important for my development in a variety of ways. That led to the textbook. I had two previous textbooks that were screening for medical disease, examination of PT practice, screening for medical disease, and kind of centered around direct access. That was kind of the scaffolding or the anchor that was built around. And as I learned more about the primary care model, got exposed to more and more disciplines involved, I started getting frustrated with kind of the narrow scope of that textbook. And I was looking for a new scaffolding, a new anchor, and that turned out to be primary care. So that really grew out of my experience in the doctor of health science experience. And that book has evolved as practice has evolved, and I'm bringing in more and more experts within our field and outside our field as this area continues to grow. Now, coming back to the profession a little bit, again, thinking about the early mid-90s, there's a group that was birthed here in Georgia, the Peach Blossom Learning Institute. Two amazing physical therapists, Geneva Johnson and Linda Woodruff, put together this institute. And the first two bullets were their kind of original goals, the mission of this group. And forum shows up over and over again, and new ideas, and new practice environments, the future of physical therapy, really trying to move the needle and stir things up a little bit, which of course they did. After a couple of years, more toward mid-90s now, the scope, the workshops that were being developed started focusing more and more on the DPT as the entry-level degree, and primary care and physical therapy about that. Really started to push that. Here's some examples of some of the workshops that they had created over the years. So the first one in '95, and then a bunch of them, 2003, 4, and 5. And these workshops were summarized in a publication that they put together, Educating Physical Therapists as Primary Care Practitioners. And Carol Davis was one of the individuals that really helped push that area. And so that group has evolved, as all groups have. About 2000, they morphed into the Physical Therapy Learning Institute. I have to say it up because I want to say PTI, one of my favorite TV shows, pardon the interruption, but it's the PT Learning Institute is what they have morphed to, and still offering a variety of workshops and innovative types of activities. Some other pioneers, again, kind of beyond the early days with the military. So it was a summary paper put together by Brian Murphy, VA in Salt Lake City, David Greyhouse, and Ivan Matsui. Just describe those three practice models. So this was published in 2005. So again, the historical perspective, the current model, and in terms of what was happening in the VA in Salt Lake City at that time, initially the really push was to duplicate the military model. And it morphed a little bit in terms of more on exercise and mobility, in terms of some of the gaps that were presenting as patients were brought into the VA facility. And although there were unique differences between the models, no surprise. These models, the doors were open when they could demonstrate increased efficiency. They were filling a gap. There were services that were not being provided, whether there's a shortage of staff or lack of expertise. And again, these are some of the metrics that we're still using today, showing the value of the services that we bring to the table. And the last quote is also kind of interesting, is that each of those models require some formal education training. Not as much as required by law, but just in terms of making sure we do it right from the very beginning. All the therapists involved are coming in at a similar level in terms of competence and competence, just to make sure this goes as well as it needs to, especially when you're piloting something. So it was a really good overview and kind of historical description up to 2005. The military model. In the 70s and 80s, I know there were some publications, but there weren't many of the articles that hit kind of more mainstream PT journals. And so it was kind of, at least for me, it was kind of a mystery. I mean, I heard big picture information about it, and there were times when I was starting to push for direct access to some of the facilities that we worked in, and I talked about the military, and the pushback was, well, that's the military. It's different here. And so the military model was just kind of blown off. And we've also experienced that some with some of the primary care models in other countries. And we bring those models up, maybe doing it here in the Netherlands or the UK. That's not us. That's not the US. And we have really missed out on, I think, really pushing the needle earlier by, sometimes I think it's just our arrogance, generally speaking, about our model compared to other models. But Joseph Moore and their group did an extensive retro-analysis of almost 51,000 direct access cases and looked at, were there bad outcomes, adverse events, did PTs lose their privileges, and in bold, this is the conclusion. I mean, thankfully, it was a really good report card, almost 51,000 cases. So this was about the time when more and more articles were coming out describing the impact that the military model had, which made it much more difficult for those of us in the public sector to just ignore it and blow it off because, oh, that's the military. Just a couple more within the same time frame. There was a practice analysis done over 20 years ago. Can you believe that? Ashley described the effort that just took that led to the House of Delegate activity. Well, there's a practice analysis done in 2002 and 3 and published in 2004. Edson Donato, Bob Duvall really drove this project. Actually, this was part of their doctoral study. Edson out in Loma Linda and Bob Duvall out at the University of St. Augustine. So this was their thesis project. And they had a statistician, and then David Greathouse and Ivan Matsui were on their committees. So they surveyed primary care military PTs, primary care civilian PTs, and then non-primary care civilian PTs, and sent out the survey. So the analysis, like our more recent practice analysis, focused on knowledge, skills, abilities that are necessary for PTs to serve in this role. Now it's listed there as primary contact practitioners, meaning direct access. So again, that really was the majority of the focus back then. We weren't quite as broad as we're looking today, but also as members of a diverse team of healthcare providers in primary care. The primary care models was also part of this effort, kind of exploring what's the skill set, knowledge base, abilities, etc. that would be necessary. So, not a big surprise, you look at the areas that are highlighted, this should look pretty familiar. What was happening in the military decades ago, it was happening more and more in the public sector these days. But imaging, lab tests, medical screening, diagnosis, prescribed administer OTCs, this came out over 20 years ago. So what happened? Why did we get specialization 17, 18 years ago? We had all this data. We had a little bit of momentum going. So what happened? Well, kind of from what I observed, and I followed up with some of the authors from the practice analysis paper, said, all right, so why didn't you push this harder? Why did this just seem to disappear? And again, there's no blame here at all. But for Edson and Bob, their goal is, I want to get a degree. They advocate within the profession. This is part of their degree earning process. And that was their number one concern. Even with the things that have been published in the early 2000s, there really was not much awareness and very little existence of PTs and primary care models outside of the military. So it really hadn't taken hold in the grassroots level from a clinical perspective. The other thing that came up was, physician shortage is what opened the doors for the military PTs. It opened the doors for the Northern California Kaiser PTs because the docs couldn't keep up with the patient load. But generally speaking, there wasn't the widespread physician shortages back at that time that we're seeing now, and have seen in the last few years. And so going to physicians to try to get some ambassadors to help us out with this push, there's some pushback, in terms of the competition for the slice of the pie. So competitors versus being collaborators was part of the obstacle. From a profession's perspective, more at the national level, the focus back then was transition to the DPT. It'd been in the works for just a couple of years, back, starting in the mid-90s and mid to late 90s. That's really where the emphasis was, as opposed to post-professional education, post-professional training. And certainly, practice acts were much more restrictive 20 years ago than they are today. Sometimes it's easy to kind of get frustrated, or we still can't do this, we're still limited here, but we have taken big steps compared to 10, 15, 20 years ago. So, there's just some of the reasons why that practice analysis effort didn't take hold back at that time. So then between 2005 and 2015, maybe 15 to 18, there wasn't much happening on a national level. Really very little at all, but there was a lot bubbling underneath the surface. And I mean, certainly at the clinical level. More and more PTs getting involved, finding ways to get into a primary care model and show value, show the knowledge base and expertise, the training that we have, and how it complements the other providers. So we really got our foot in the door in a lot of facilities, from large private practices to small concierge practices to large health systems. Really took a foothold. And that is what we didn't have back in 2003, 4, and 5. So it resurfaces. And as you mentioned, this is the Alabama delegation. These are the people that brought this RC forward in 2015. So investigate and identify roles, services, and opportunities. And with the idea of providing a historical overview, how do we get to where we are today, back in 2015, and current initiatives and what comes next. So at that time, there was no primary care SIG. So it landed under the umbrella of APTA staff. And I had joined APTA staff in September of 2015, and so was there for the beginning of this. And I just want to give kudos to the work group that was put together. And Hadia Green Guerrero was the staff lead on this, did a great job. But you'll see some familiar names on this list. They did a lot of heavy lifting in terms of digging in from a history perspective, and current existing opportunities and future opportunities. And they put together a great report. And again, this report, this perspective paper, was published. The first two recommendations, as you mentioned, were to initiate the petition process for ABPTS and ABPT-RFP. Now, what made this a little challenging was that all the previous efforts working towards specialization came from a section, back in the section or an academy, where geriatrics was the whole focus of that group, or pediatrics, this was their whole focus. Well, at APTA, there were lots of things to focus on. And so there was a lot of competition for staff time, work group time, to put together this petition in a relatively timely fashion. The other thing that made it a little challenging is that all the applications previously coming to ABPTS in particular came from a section or academy, not the mothership. Well, the mothership controls the budget for ABPTS. So there was some discomfort early on. If this petition comes from the APTA board of directors who control our budget, how could we say no? I mean, so there was pressure related to that. So we hired consultants, but we started the process, and then thankfully the primary care SIG rescued us, federal section rescued us. So we were able to hand it off in 2020 when we did hand it off. And so up until then, the petition one had gone through the process, but there still was a lot of work to do. And Ashley mentioned, but I just wanted to highlight how much effort all the detail, the information that went into this petition, was a lot of heavy lifting here. So we have to demonstrate a need, a demand, what are the specialized knowledge and functions, the training, all kinds of signatures and letters of support from within the profession, beyond the profession, the practice analysis done over and over and over again, setting up description of specialty practice, all the way down to the final approval of ABPTS board. And this was a different animal for them compared to other specialties that had come in previously. So we had to convince people that had an OCS, pediatric specialist, geriatric specialist, that this belonged at the same table as the previously approved specialty areas. And then it went to APTA Board of Directors, and hallelujah. 376 votes in the affirmative, as it turned out. And when the slide came up with the numbers, I was with Ashley and John Hike and others in the gallery. Christy, of course, was in the house itself, and it was exciting, but it was just kind of disbelief. I never thought I would see the day when this would happen in my professional career. It's like, it just happened. It's unbelievable, the climb. So again, appreciate the climb that it took to get there, and especially those last couple of years that built on all the activity in the decades leading up to that. And that, again, that's what was missing back 20, 25 years ago. So we had the scaffolding set up, the foundation was set up, which is why it worked this time. And those bottom two levels was what happening on the clinical level. Without that happening at that level, we never would have made it to the finish line. And that's you folks. That's where you folks come into play. So kudos to everybody involved. So, what impact? Besides getting approval, which of course was the goal, the impact goes beyond that. And Evan mentioned this. We have a definition, a consensus-based definition. I think 10 years ago, much less 20 or 25 years ago, if it has 10 different PTs to define primary care, I guarantee you'd have 10 different definitions. My guess is today, if it has 10 different PTs for definition, we maybe would get 4 or 5, which is a lot better than 10. We have some work to do, but we have a consensus-based definition description of what this area specialty practice can be. There certainly is increased awareness. This happened at multiple levels that led to the House of Delegate approval. Acceptance from the House was huge. And along the way here, we developed educational tracks, certification programs at APTA, at the University of Alabama. Folks created a track there. We defined health education, military health education, certification programs that hopefully we can build upon, especially we start talking about residency education in the area of primary care. So besides the goal being met, I think we've had impact in other ways that are really going to benefit us down the road. But ultimately, the goal is to impact patient care, right? That's why we're investing all this time and energy, for us to get into the models, so the doors open wider for us, and then of course make a difference in terms of the quality of care being provided. And that fits into our association's vision statement. This is our goal. And I can't think, I'm biased here of course, but I can't think of a better model for us to have the ability to impact the health society than the primary care model. And again, doors are open for us. So it's game time. Now, if I was into performing arts, I'd say it's showtime. But I can't sing, I can't dance, so it's game time. Part of it's because Jill and I own the Green Bay Packers. So it's game time. In fact, I can see the cursor, maybe a little cursor. So our owner's suite is right down here. Section 106, row 12, seats 10 and 11. We've had those owner seats for over 40 years, so it's game time. So, you know what that means? Up till now, we've been preparing, we've been practicing, all right, and trying to prepare as best we can, but now it is showtime, it is game time, and we need to be ready, and again, I have confidence that we will be ready. So, specialty exam, and then also APPDRP, developing primary care residency programs. We have the approval. Now, as I said, it's development time. And hopefully, and some of you already have put your names in to participate in that process. But we also need some big time parallel efforts to the development of the exam and the development of residency programs. And the idea that, you know, from the movie, if you build it, they will come, and it ain't gonna happen. Just because we have an exam doesn't mean anybody's gonna take it. Just because we have the ability of primary care residency program doesn't mean we're gonna have one. If we don't take hold of things here and really push and make movements. So in terms of the certification exam, things that we can all do, I already mentioned there is enhanced awareness already, and that's what led to the House of Delegates approval. But those who are membership, they're not members of the House. In fact, unfortunately, probably 7 out of 10 licensed PTs in the US are not members of the APTA. So to think that now all PTs know about this, there's no way. Most PTs are unaware of what's happened at the House and what that means. I was just out in California teaching a residency fellowship program, and the director's been very involved in the residency world, the fellowship world, and big health system. And I said, yeah, you talked about primary care residency. And he said, oh, our system's not ready for it. We're not ready for direct access yet. And I said, well, primary care does not equate directly to direct access. It can be part of a primary care model, but they're not synonymous in terms, nor models. Well, he was unaware of that. I talked to another person who'd been long involved in the residency fellowship arena for decades. And again, I brought up what had happened at the House and potential for residency programs now. And his assumption was it was going to be the military model, focus on MSK and triaging only. And I said, well, that's part of it, but it's not all of it. And these are people in the know. So we have work to do to inform the masses that it exists and what exactly is this animal and what it means. And of course, push the value, in general, of specialization in general, and we have a track record in other areas. And anything we can do to enhance participation, and again, coming around to the idea this is all about the patient, and the benefit, the delivery of patient care. So if we can get the word out, we recruit, we support. Those of you working with entry-level students, you have a huge opportunity when you talk about specialization, post-professional education, and professional growth in general. Huge opportunity. And now we are finding and have a mechanism for our generalists to have a professional development pathway. You know, for years they kind of floored me, and I'm clinically, I'm very much a subspecialist, which I read a book that's defined as someone who knows more and more about less and less. and that's probably true. Think about our primary care therapists, they're being asked to know more and more about more and more. And we don't have a professional development track for them until now. So that's the beauty of this. And I just have to believe that that's going to fit a huge segment of our graduating students, early career PTs. So recruit, support, and then certainly participate in activities itself. Hopefully there'll be a number of us in this room that sit for the exam at the time. And hopefully there are numbers in this room that will help be part of a primary care residency program as well. So the residency education, the collaboration, it's a lot of work to create a program from scratch. And I just, Jill and I were up at University of Wisconsin-Madison, and we helped create an orthopedic PT residency program. And at the time, there were only 2 or 3 other programs that had gone through the credentialing process. And so I called Joe Godges in Southern California, Carol Joe in Northern California. They shared everything with us, their entire curriculum, all their paperwork. Not that we just rubber stamped everything and did exactly what we did, but just to have some semblance of a starting point, it saved us a boatload of time. And then we tried to pass that forward when budding programs contacted us. So hopefully we can do the same thing amongst us for the early residency programs. I mentioned already some of the certificate programs that are out there. I'd like to think that some of the curricula that have been developed for the certification programs can be fit into a residency model, provide a lot of the content for the residency model, so really it's mentoring that's left is a primary item that is left behind there. It'll just save time, and we don't have resources to reinvent the wheel. And we've got a good start out there already. So, go from within the profession, we're on the home stretch here, to looking outside the profession a little bit. And in order for us to really make the impact that I think we are striving to make, we need to continue to broaden our team and look outside of our profession. So primary care providers, whether it's physician or nurse practitioner or PAs in that model, dietitians. I think about a summit like this. What I understand, in the first summit, there was a multidisciplinary panel. Some non-PTs on the panel. How great would it be if we had a couple of primary care physicians here or nurse practitioners here, whether they're presenting, I mean, so that's how you get them in the door. So we learn from them and they learn about us. And the more they learn about us, the better chance they're going to be a good ambassador for us when they go back to their work setting. They talk to their medical colleagues. Hey, I went to this conference full of PTs in primary care. Guess what? This is what they're doing. This is some of the roles that they're playing. Maybe we should consider that here. So they can be ambassadors for us for making changes within health systems, opening doors for private practices. And again, for me, early on with Charlie and Mike, they really opened doors for me as I better understood their training and their scopes of practice, and again, how we could more better interface. So I think that makes sense, and we're doing that to a degree already. But I don't think it's allowed. But how nice would it be if on the primary care specialty panel that we had a member at large who was a non-PT, again, whether a physician or a nurse practitioner, who just gave a little different perspective. How about if we had a non-PT, but someone in primary care who was one of the item writers for the exam, maybe just one of the final reviewers, so we could learn from them, and also they learn about us, and we'll go back and can be potentially good ambassadors for us. And then last, the public. Most importantly, the public. We have some work to do here. I want to thank Tara Jo Manal for the upcoming slides here. ABD has put out a number of dynamite reports in the last 3.5, 4 years, a series of them. And this is one that came out in November of 24. They surveyed primary care physicians about their perceptions of our profession. So they got feedback from 400 current practicing physicians. So primary care, family, internal medicine. And the idea is to explore their perceptions and referral behaviors, barriers to referring patients to our services, and components of an optimal collaborative relationship here. And then future, what can happen down the road here for us. So thankfully, they like us, is one of the bottom lines, which is always nice to hear, that affirmation. The majority view us in a very positive fashion. They trust the care that we provide. Collaborating, 96% collaborating with us would benefit the patient care being delivered. So that is a really good starting point. But aligning the primary care physician's perception of the consumer related to our practice and profession. And I've bolded a couple things in particular here under the consumer aspect. So to the provider of choice, the consumer, they don't consider us to be the provider of choice. We're the PT's first choice providers after PCP. After the PCP. And we'll see it's quite a disparity. So we're not the practitioner of choice in the general consumer's eyes. What they value most from us is effective treatment, kind of the treatment aspect. Not about the diagnostic process, the clinical decision-making aspect per se, but treatment. So where do they go for a diagnosis? They go see their primary care provider. And their PCP will decide based on their diagnosis whether PT is indicated and then make the appropriate referral. I mean, that's been the classic model forever. It's not saying it's not a bad model. We don't want to get rid of the physician referral model. But boy, it'd be nice if we kind of moved up the list of provider of choice from the consumer's eyes. But until the consumer understands that when they come to us, that they're going to get a diagnosis, we'll never be up near the top of the first provider from a consumer perspective. So we have some work to do there. So again, very similar. They see the primary care physicians as the gatekeeper, and they have very little interest in direct access, even if it's available, because they don't view us as the first contact provider. So all that effort for direct access, this is another example of getting Practice Act changes put into place. That's the easy part. Implementing the day-to-day practice, that's the hard work. That is the challenge. And to me, that's what I see. 10 years from now, Ashley will look back and say, getting approval of the house, that was the easy part. Look at all the work we've done since then. And then for referrals, that second item there, referrals given usage. So 35% of the patients who were given a referral to PT never went. They never went. So you would think getting the referral out there would bring people to our doors. Well, sometimes, but a third of the time, they never follow through. So what are some of the barriers with that? Well, they don't want to go. I can get that. People are busy and people have different opinions. Patients lack aware of potential benefit. Why am I going to go? And from a physician perspective, they can't describe necessarily the value, the things that we might be able to offer. And patients believe it's too costly and too time-consuming. So that's where the copay comes into play eventually. Potentially, they have to take time off of work, which a lot of people can't do anymore. And everybody's busy. Right? Everybody's busy. And it's just more time. And a lot of clinics, their hours match the typical workday for lots of people. So we're not accommodating people's busy lives. I'm making huge generalizations here. I get that. Then the last one is patients have limited access. So a shortage of PTs. I was on a webinar with the APTA certificate program, and one of the people on the panel was the only PT in a county in Eastern Oregon. One physical therapist taking care of the county. There are shortages for us too, especially geographically. So just to kind of summarize, the first couple bullets are, I think, self-explanatory, but primary care providers, they need help in terms of convincing patients, so that's on us. Work with our referral sources, our collaborators. The better they understand our practice, the better we understand their practice. It takes effort to bridge this communication gap. And there's the patient's perception that we do not collaborate enough with the primary care providers, the PCPs. Now, I'm sure a lot of patients are not aware at all of the efforts that we make in terms of collaboration and communication, but from their perspective, we don't collaborate enough. So we've got some work there in terms of public perception. And then the last piece of data here, so a consumer survey, and it backs up a lot of what the primary care physicians talked about as well. So the numbers are getting better in terms of how the public views us in a more positive fashion, a little more acceptive of direct access as well. So PTs are viewed positively by both users of PT and non-users, so 87 and 61%. Very few had a negative impression, so that certainly is good news. And then for the most part, visits are beneficial or somewhat beneficial. The good news is 84% would refer friends or family to a physical therapist. That's a really good sign. Now, if they think that they have to go see their primary care physician first, kind of defeats the purpose, but there's some potential there. PTs increasingly viewed as movement experts. That's been our push within the last 8 to 10 years or so. Certainly since our last vision was adopted by the House of Delegates. So compared to other healthcare providers, the movement's kind of in our wheelhouse here. More consumers, almost a 10% increase, believe that PTs have greater knowledge than their regular doctor for these items here. That language bothers me a little bit, because to me this isn't who's better, but who's competent. It bothers me when we say, well, we're better than the primary care, we're better than the internists. Look at the data here. Well, that's really not the point. It's who's competent to provide the care. So we as competent as these physician groups. To me, that just sounds a whole lot better, especially in terms of team building. Health and wellness, pain management were viewed in a positive standpoint. Majority of consumers still prefer to see their PCP before a PT. So that goes along with the same thing with the primary care physician's perspective. Again, who's the gatekeeper? It's not us. And in terms of only 10% of physical therapy users and 7% of non-users, that number say they would see a PT first, even if insurance covered it. Those aren't good numbers. We have some work to do here. On the consumer level, the public level. So again, a lot of overlap. So patients don't see desired collaboration, that came through again. Human movement system does not resonate with consumers, at least not yet. Movement experts, area of expertise being movement, that's part of our primary focus here. But the human movement system, it hasn't resonated out to the public yet. And we have a lot of work to go there. Top barriers, same thing. Too costly, too much time, and not available in terms of geographic convenience. So the opportunity, a lot of opportunities are out there. Within the profession, outside the profession, it's kind of overwhelming. Oh my God, how are we going to do all this? Well, it doesn't just fall on our shoulders. I mean, one of the things that I would ask all of you, including asking myself, is when we go back to our home bases, is to engage, and I speak to the choir here, I understand that, but to go back and talk to our colleagues, those who are members, those who are non-members of APTA, those of you that are teaching academic sector, again, to kind of keep reinforcing the idea and the role that PTs can play in this primary care model. Post-professional education certificate programs, again, to highlight that this is an avenue for professional development, and we just need to engage more and more people and kind of recruit them, as many as possible, to help with the cause. So whether it's internal, related to the exam, or how to create a residency program, or really to be ambassadors for our profession and to those outside of our profession. You know, which all of us do on a day-to-day clinical basis. Think of the millions of opportunities. We have well over 200,000 licensed PTs here in the U.S. You look at our daily patient load. Every patient encounter is an opportunity to educate, to inform. And you kind of work these little points in here and there, through a particular visit, but it is an opportunity to help kind of move the consumer in a direction where they recognize is the way that we would like to. And then mentoring. You can't mentor everybody, but again, looking ahead to succession planning for leadership, whether it's in the section, the effort for the primary care specialist panel, the item writers. Again, you latch onto somebody who's passionate, really interested. Kyle, you're on the list since you're the only student here. Again, mentoring people along the way to make sure that we've got the next generation of leaders who can really build on what has occurred within these recent years. And again, it has been a blast to be on this journey with you, and I look forward to continuing as long as